Welcome, Dr. Varmus. Thank you for joining us today. As you well know, this year marks the 50th anniversary of the National Cancer Act, which included an explicit global mandate for the NCI, and this year also marks the 10th anniversary of the creation of a dedicated NCI Center for Global Health. So we really wanted to use these simultaneous anniversaries to have what we're calling global cancer conversations with key leaders to speak with them about their views on the current state of global cancer research and control. Your name, of course, rose very quickly to the top of the list of possible guests because you were the NCI director in 2011 who decided to create an NCI Center for Global Health. I have to say I was personally grateful for this decision back then as I finished my fellowship training and embarked on a physician scientist career in global oncology based in sub-Saharan Africa, and I remain grateful now, having been recruited to the NCI a year ago to direct the center. I often emphasize to people that global health at NCI long predates the creation of CGH, and even now is not confined to CGH. So given that, I wonder if you can tell us a little bit about why creating a dedicated Center for Global Health at NCI in 2011 seemed necessary.
Sure. Well, thank you for that introduction. I've had a fairly extensive history in thinking about global health ever since I was a medical student in India in the late 60s, and contemplated a career in global health myself, which never came to fruition. But when I was NIH director in the 1990s, I put a lot of effort into trying to develop better research tools and better ways to carry out medical care in less affluent parts of the world, focusing explicitly and for many reasons on malaria, a disease that was pervasive, lethal, open to a lot of research opportunities, and underfunded. And through that effort, we developed a multilateral initiative on malaria that is still a pretty vibrant force, especially in Africa to this day, over 20 years later. So when I came to the NCI as director, one of the things that I noted was that there was a strange confluence of things happening at the same time. The UN was becoming increasingly interested in non-communicable disease as well as infectious disease and its efforts to improve global health. Secondly, the number of cancer deaths in the world was rising dramatically in the most impoverished part of the world. And while, as you point out, NCI had a long history of doing a variety of things abroad, seizing research opportunities, taking the initiative in certain countries where fortuitous events like the discovery of Epstein-Barr virus was helpful in thinking about diseases that were unique to certain parts of the world and provided unusual research opportunities. There was no coherent, systematic plan with a clear international program for trying to improve cancer care and cancer research throughout the world. So it seemed to me that there was an opportunity for the NCI to play a major role in making such a systematic approach to global cancer research and global cancer health. So we held a couple of meetings at the NCI, bringing in experts from around the world, mostly domestic, but many international partners as well, to think about what a program would look like and how it might be devised. We recognized that it wouldn't work without making some choices. The budget wasn't going to be infinite, and it was going to be critical to have partners both in the US and around the world. And we had to have a plan that recognized we couldn't do all things in all countries, but we could use some countries as important stations for trying to develop a logical approach that would be both generally systematic, but also unique to each area. And that included making plans for a variety of things that perhaps we'll discuss as we go along here.
Great. You alluded to this a little bit, an interest in global health that began, I think, from your medical student days. I wonder if you could elaborate, or were there specific personal experiences that you recall having either in early life or your career that spurred your interest in global health? Because certainly we're grateful for that, but not all people share this interest.
Well, I am an international person. I believe I have a one world concept, and I went to India as a medical student, not because I was interested in cancer research particularly. In fact, the place I served for several months saw very few cancer patients, with mostly tuberculosis and leprosy and other infectious diseases. But as somebody who is interested in a variety of cultures and having international experiences, I was drawn to that aspect of life. And as NIH director, after many years, mainly running a laboratory, I saw an opportunity to make a contribution in an area that had always been of interest to me, but an area in which I had really done very little of substance in all those years after that trip to India.
Thanks. I'm going to try to bring us forward a little bit now. So we spoke about 2011 and some of the circumstances then. And now, of course, it's 2021. I'm curious, in the decade since CGH was established, how do you feel the field of global oncology has changed, or has it in your mind?
Yeah, I think it has changed some, but of course, we're still, as an organization, the NCI is paying attention primarily to cancer in the U.S., with the assumption that advancements in our understanding of cancer and cancer prevention, cancer treatment will have its downstream consequences in other parts of the world. But I do think that at least in the years that I was intimately involved in running and contributing to the global efforts made by the NCI, that some important things happened. We identified a number of countries where important things could happen pretty quickly, in part because there was buy-in by the national government, because there was already a start. There were cancer hospitals, there were universities that were committed to doing something about cancer research. During my time at the NCI, I traveled on behalf of the center to Turkey, Indonesia, Uganda, Mexico, and a few other places. Indonesia, explicitly for the purpose of trying to get a better understanding of global cancer research, in part to try to advance different issues in different places. Tobacco control and smoking cessation in Indonesia, for example, the greater use of human papillomavirus vaccines in certain parts of the world, India especially, and Mexico, encouraging countries to try to establish a national cancer plan. As I mentioned, having a strong buy-in from people who ran medical and research institutions in the target countries that where we were emphasizing our programs was incredibly important. Very early on in the process of establishing the new center at the NCI, along with a colleague at the Cancer Research UK in Britain, we held an international meeting that resulted in a menu of activities that might be useful in different places, ranging from screening, prevention, treatment, hospital systems research, and informatics infrastructure, just to put into a categorical framework the kinds of things that centers might do. Of great interest to us was the establishment of registries, so we actually knew what cancers were occurring and were killing people in different countries, so that efforts could be placed in both research and in clinical settings on the diseases that were most pervasive and most lethal in different countries, because as you know very well, the incidence of these diseases does vary dramatically among the countries that were working with us. So I think it's just establishing a framework for thinking about how you approach a country, how you get committed and enthusiastic partnerships going, was very important in those early days, and took us away from the kind of anecdotal approach where if you had a friend somewhere and they wanted to do something, a project might emerge, to a time when we could say that there's a lot of interest in fostering cancer research in a specific country. Here are the big problems. Here's what's missing. I don't think it's easy because these collaborations are often based on the political situation in those countries. And for example, in Turkey, when I went to visit, I believe 2011, there was a tremendous interest in expanding research in Turkey and building stronger cancer care. I would say that that's one of the places where changes in the political environment have been unhelpful, shall we say, to fostering these collaborations. You may recall that in the late 1990s, before I came to the NCI, when I was working at the NIH as director, there was an effort that was fostered to a very significant extent by Rick Klausner, who was then the director of the NCI, to build a Middle Eastern cancer consortium. And that seemed to work for a time, but political difficulties made it hazardous after that. But you know, that I think trying to build international collaborations, even if the U.S. is not leading them, is an important role that the NCI can play in trying to promote coalitions of research activities that can be politically beneficial. We worked on that in Ireland in 1998, 1999, and I think we helped to foster some of the agreements that have led to cessation of hostilities in Ireland.
Yeah, it's great that you mentioned the Ireland agreement. This was just renewed, and I think President Biden actually mentioned it in his remarks with during his recent meeting with the Irish Prime Minister. I'm curious about moving forward. Having I think worked to really establish a more of a comprehensive framework structure rather than these opportunistic sort of engagements. What more do you think the NCI can contribute going forward? Do you think it's largely continuation of the same? Are there specific new opportunities that have emerged that you think we should capitalize on?
Well, I think there are always opportunities from a political perspective to work with certain partner countries that are especially interested in global cancer research. And obviously, the UK is one of those, Scandinavian countries, other countries in Europe, just to get a coalition of funders who can do things more efficiently working together. It's not always easy, but that still seems to me a useful way to proceed. I haven't been particularly involved in what's going on at the UN, although recently I've taken on a new position at the World Health Organization as the chair of their new Science Council. And that might be a place where some recommendations from the NCI could be helpful in thinking through what the scientific opportunities are for improving health. The UN is certainly still committed to non-communicable disease control and improve research in those domains. And it seems to me that that organizations like the NCI and Cancer Research UK and cancer agencies in France and Germany and Scandinavia might come together to bring to the new science directorate at WHO some proposals for how they could broaden their efforts in trying to do cancer research worldwide. The difficulty is always deciding what to do about countries that are not really prepared to pitch in, but would like to see cancer rates decline and cancer mortality reduced. And it's hard to work with those countries. My bias is that we should be focusing on countries that show a willingness to work on these problems, have some resources, have some investigators who can help locally to lead programs, who are willing to put together a national cancer plan with actual milestones for improved HPV and HPV vaccination, with smoking cessation programs, so things that obviously pay big dividends. Interest in screening of certain kinds, interest in adopting genomics. One of the things that we're thinking about at WHO is ways to expand the use of genomics in medicine. And there's no doubt that cancer research will be high on the list as in cancer care as well, and efforts to make wider use of the advances that have been made in cancer in the use of genomics in medicine, building genomic centers, building an informatics infrastructure for knowing what mutations are being found in those places can be very important. I've been heavily involved myself in a project being coordinated by the New York Genome Center to study the influence of ethnicity and race on constitutive genomics, perhaps a better way to say it, on cancer incidence and cancer outcomes, the effectiveness of cancer treatments, and working here in New York with its very diverse populations, but extending those studies to the place where these diverse populations come from seems like a very wise idea. We have the International Cancer Genome Initiative as a place to try to promote these ideas, and there is increasingly collection of information about cancer genomes and constitutive genomes that are found in people who are predisposed to cancer is, I think, a very fertile way to make use of these advanced technologies that have now gotten a lot cheaper, and try to understand why the variations in the incidence of certain cancers are so profound.
You raised a couple of things that I wanted to ask you a little bit more about. So the first is the WHO Science Council. And just for people listening in, you were recently asked by WHO Director General Dr. Tedros to chair a new WHO Science Council to provide advice on high priority scientific issues that could have a direct impact on global health. So I wonder if you could talk a little bit more about that group, your role, what you hope to accomplish in this new council as chair.
Well, it's premature to say too much about what we're going to do. We've only met once, and it was largely a meeting to get to know each other. It's a small council, though, thus far, with only 9 members. I think it will be enlarged in due course, but I think there is general agreement. I don't think there needs to be any secrecy about the idea that one of our first things to talk about and work on will be ways to more widely implement genomics in medical research and various aspects of healthcare, prevention and treatment, and especially diagnosis. And that will apply, of course, across a broad spectrum of diseases. In this era of COVID-19, it's inevitable that a lot of the interest will be in the use of genomics in diagnosis and following pathogenic organism evolution in infectious diseases. But of all the chronic non-communicable diseases, the one that will attract most attention will be oncology, where the use of genomics has become pervasive, at least in the advanced economies. So exactly how we're going to go about learning what needs to be done and writing a report remains to be seen, but I think there will be additional approaches as well. I know we'd welcome suggestions from member countries, of whom there are 194, to help us think through the kinds of things we might do next. Our goal is to identify technologies that are coming into widespread use or show the promise of widespread use, and to think about where those technologies might be applied, so that we don't find that the advanced countries are getting ever further ahead of the countries that are middle and low income. So the goal is not to say disease X needs more attention. There are lots of diseases that need more attention, but the idea for our council, at least, is to think about what science is producing that's broadly useful in medicine and medical research, and to look for various ways that those methods can be applied, and to think in a very pragmatic way about what it takes, by training people, by buying instrumentation, by bringing in the private sector, by doing other things to hospital systems in a way that allow those new methods to be used in a variety of countries.
So you've spoken about genomics as a tool for achieving health equity or addressing health equity, both in New York and internationally. And I just want to ask you about kind of a related topic. You've written recently in Science about concrete steps needed to diversify the scientific workforce, which of course is distinct but a related topic. Do you see these efforts as connected to global health, or do you think equity and diversity outcomes are best approached somewhat separately in the domestic and
Well,
global arenas?
that's an interesting question and one I've given some attention to. And I do think that there are special. You don't want to lump everything together and make everything one problem, but I do think that there are special attractions for people who have traditionally not been well represented in science and medicine to get engaged because of the connections with global health. That's where people came from. I know that some of our most interesting and inspiring young people who are working with us on the Polyethnic 1000 program at the New York Genome Center are people who can track their ancestry to Africa or to China or to India. And that is an inducement to them to get more engaged. So I do think that, that all these programs are going to require people who are not just smart and ambitious, but have vested interests in the outcomes of the research they're doing. And I do think this is one. We need many motivators to encourage people to enter careers where there's a very long training period, a long time before you begin to generate real financial returns. And I do think that the goals of global health of all kinds, cancer too, but all kinds, can be a motivator to get folks who might see more rapid returns in financial industries or communications industries or other places to consider a gratifying but perhaps less lucrative life in science.
Great. I think my parents are still waiting for my global health career to be as lucrative as some alternate career choices might have been.
Where are your parents?
They're in North Carolina. They're Indian immigrants, from first generation Indian immigrants who I think might have imagined more lucrative careers for me, but I think are happy with what I'm doing regardless.
You're doing noble work, so
Yeah,
glad to have
thanks.
you there.
So finally, I just wanted to give you an opportunity to, as we start to wrap up, to share any other parting advice that you have for the NCI or for the Center for Global Health as we prepare to enter our second decade.
Well, I confess that I have not kept up at a detailed level with what the center has accomplished over the last few years. I'm glad to see they've been successful in recruiting a new leader, and that's great. I can sense your enthusiasm and familiarity with this job. But certainly the things that I was most eager to accomplish, and don't think we were incredibly successful. We had some successes, but not as many as I would have liked, was to establish a worldwide coalition of involved research institutions. The meeting that we held in London in collaboration with Cancer Research UK was successful at one level. That there was an interest in uniting our efforts, combining a number of European, but also South American and Asian scientific societies, and a few African societies to try to work together, especially on tobacco control, vaccination programs. That we never really built the kind of international coalition that I had hoped for. I'm quite familiar with a new research enterprise that's being conducted by the NCI and CRUK in the grand challenges domain. But most of that is very high tech and not really directed to the kinds of problems that you find when you go and examine cancer care in Africa and even in places like India and China. I think it would be useful to have, I don't know if we need another convening body, whether the UN or WHO needs to bring folks together, but one of my recommendations to you would be to to find out who was leading the similar efforts in Europe and Asia and other places, perhaps through some of the genomics efforts that are now being made throughout the world to understand cancer genomes and what contributes to them from the germline, and to seize on that, as well as tobacco, HPV, and a few other consolidating factors to make things work. I think if that kind of coalition led to some advance, like an Epstein-Barr virus vaccine, for example, or to much higher rates of HPV vaccination, which is rates that are still really embarrassingly low in some parts of the world, that would be a way to show that these coalitions do work. Because I don't think in the very near future the NCI is going to have the resources to do what needs to be done in other parts of the world. We can help in various ways by training people, by setting standards, by laying out the kinds of programs that are necessary, encouraging people to write national cancer plans. And one thing that I would ask, for example, is whether Mexico, with whom we worked closely for several years to develop a cancer plan, has acted on that plan. And I think the follow-ups are often lacking. And I would encourage you to look at the countries where the Center for Global Health has taken actions in the past to see whether those actions have actually borne fruit and whether there's potential for fostering and enlarging partnerships that showed promise at one time.
Thank you for that advice. I think it really speaks to a lot of the ideas and conversations and things that we're doing now. And one thing we've avoided mentioning until now is, of course, COVID, I think, hopefully will provide opportunities to re-engage in the type of coalition building that you have alluded to, and that really have been an important priority for the center since it was first established 10 years ago. So I want to be respectful of your time. I think we probably should try to end it there. I want to thank you again, Dr. Varmus, for sharing your thoughts with us today in this global cancer conversation. And thank you again for establishing CGH 10 years ago. I sincerely hope we can continue to draw on your counsel and support in years to come. So thanks again.
I hope we can do it in person as well.
Yes, we'll look forward to that. Thank you. Bye.
Bye.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.